Aortic dissection, which is a relatively uncommon but life-threatening acute condition. It's defined as a separation of the layers of the aortic wall due to an intimal tear that creates a second blood flow channel. Blood may flow in between the layers of the blood vessel wall as the tear extends, which can lead to aortic rupture or decreased blood flow to the organs. Aortic dissection is a medical emergency, since it can quickly evolve to full-thickness tearing due to the weakening of the aortic wall to the extent that it can no longer support the forces imposed upon it, leading to a complete rupture. Risk factors for aortic dissection include advancing age, male sex, hypertension, pre-existing aortic aneurysm, and atherosclerosis. For individuals under 40 years of age, other risk factors are often present, such as connective tissue disorders, vasculitis, bicuspid aortic valve, aortic coarctation, Turner syndrome, prior aortic valve surgery, trauma, and the use of amphetamines or cocaine. Aortic dissection classically presents with sudden onset tearing chest pain that radiates to the upper back between the scapula. Pain can sometimes be associated with syncope, stroke, myocardial infarction, heart failure, or other clinical signs of end organ ischemia. On physical exam, the blood pressure in both arms may be unequal, and an aortic regurgitation murmur may be heard. A diagnosis of aortic dissection depends upon finding the dissection on imaging studies, which defines the extent of aortic involvement. A chest X-ray shows widening of the mediastinum, which is a helpful clue, but is not a specific sign for aortic dissection. The diagnosis is usually confirmed with a CT angiography showing a true and a false lumen, and this is generally done as the initial imaging study in hemodynamically stable individuals. If the CT angiography is uncertain or further definition of the dissection extent is needed, other imaging studies like a transesophageal echography or TEE or an MR angiography are indicated. On the other hand, for hemodynamically unstable individuals, the initial imaging study recommended is TEE. Aortic dissection is classified with the Stanford classification as Type A and Type B dissections. Type A dissections involve the ascending aorta, regardless of the site of the primary intimal tear, while all dissections that spare the ascending aorta are classified as Type B. It's important to recognize the difference because the treatment differs. Type A dissections are treated with emergency repair with open surgery or endovascular treatment with TEVAR. This is because in Type A dissections, rupture may cause blood to leak into the pericardial sac, resulting in a life-threatening cardiac tamponade, which is the most common cause of death. Kind of like a zipper, a dissection can extend into other arteries where the false lumen compresses the true lumen, obstructing blood flow and causing organ ischemia depending on the involved arteries. On the other hand, Type B dissections may get initial medical therapy with beta blockers like esmolol as anti-impulse therapy to lower blood pressure and decrease the velocity of left ventricular contraction, which ultimately decreases aortic shear stress and minimizes the tendency for the dissection to propagate. Indications for repair for Type B dissection include occlusion of a major aortic branch leading to end organ ischemia, persistent severe hypertension or pain, propagation of the dissection, expansion of an associated aneurysm, and aortic rupture. Alright, as a quick recap. Aortic aneurysms are usually asymptomatic and are discovered incidentally while performing an imaging study for an unrelated condition, generally ultrasound for AAA, and chest radiography for thoracic aneurysms. Risk factors are an indication to perform periodic screenings, and they include hypertension, increasing age, male sex, smoking, atherosclerosis, having a family history for aneurysmal diseases, having aneurysms in other arteries, and, rarely, genetic syndromes. Aortic aneurysms can evolve into a complete rupture. Most cases of aortic rupture present with the classical triad of severe acute pain, a pulsatile abdominal mass, and hypotension. This may rapidly cause a massive hemorrhage, possibly evolving into shock and death. To avoid this, asymptomatic aneurysm should get conservative management, which includes smoking cessation, antihypertensive therapy to control blood pressure, statin therapy to lower cholesterol levels, and antiplatelet therapy for cardiovascular disease. In addition, they must be followed up with imaging to evaluate the diameter and expansion rates. Above a certain diameter threshold or expansion rate, the aneurysm should get elective repair, which can either be open or endovascular aneurysm repair. For AAAs, repair is recommended if the aneurysm is or becomes bigger than 5.5 centimeters in males or 5 centimeters in females, or is rapidly expanding, which is defined as an increase in maximal aortic diameter of 5 millimeters or more over a 6-month period of time, or more than 1 centimeter over 1 year. For thoracic aneurysm, rapid expansion is defined as more than 10 millimeters per year for those with sporadic degenerative thoracic aneurysm, and 5 millimeters per year for those with genetic syndromes. Regarding diameter threshold for those with sporadic degenerative thoracic aneurysm, the threshold for elective repair of ascending thoracic aneurysm is an end diastolic diameter of 5.5 centimeters, while that of a descending thoracic aneurysm with a low risk for perioperative complications is with a diameter of 5.5 centimeters, and for higher risk individuals, it's 7 centimeters. On the other hand, the diameter threshold of thoracic aneurysms associated with genetic syndromes is 4 to 5 centimeters. Finally, symptomatic aneurysms should always get surgical repair regardless of their diameter. Last but not least, an aortic dissection is where blood tunnels between the tunica intima and the tunica media, separating the two layers and creating a false lumen. Aortic dissection, in most cases, is associated with a sudden onset of severe pain, often described as tearing, and can evolve into a complete rupture. An aortic dissection can lead to emergency situations like cardiac tamponade and shock, and should be treated immediately.